Thank you, Kelvin. On behalf of Cardioscan Singapore, I'd like to thank the Singapore Heart Foundation for inviting me to talk on this, what I call intriguing topic. It's a wonderful to enter the world of Wenckebach block. And we take it for granted that it's just simple looking ECGs. But when we look further into it, we can see a large number of different combinations. Let us ask who Carl Friedrich Wenckebach was. He was born in The Hague, Netherlands, and in 1888 got his MD, and in 1898 saw a patient in her early 40s with an irregular pulse. Remember, this was a few years before Eindhoven in 1901 designed the first ECG machine and put it into clinical practice. So Wenckebach did not have an ECG machine, but rather he worked out the relationship of atrial and ventricular contractions using a smoke drum. For those who think that this was very primitive, which it was, this is what I learned my physiology on during the 1960s. It was a drum with a piece of paper stuck to it, and that paper was black because of smoke, and then we could have a stylus go through it and record what was happening physiologically. So Wenckebach used the carotid artery, and he used the jugular vein to determine that there was a discrepancy between the atrial and ventricular contractions. And as you can see on the lower line, the A and C of the jugular venous pressure was narrow to start with. The next beat was wider, and this is atrium to ventricular contraction. And then atrium to ventricular contraction increased again, finally ending with a drop beat. This was called type 1 second degree AV block, or Wenckebach, or Mobitz type 1. 1906, before ECGs were generally used, Hay described type 2 second degree AV block, or Mobitz type 2, and it was left in Mobitz in the 1920s to classify this using the electrocardiograph. In summary, Wenckebach or Mobitz type 1 is a progressive lengthening of a PR interval with a drop beat. It is predominantly in the AV node and therefore has a narrow QRS. Whereas Mobitz type 2, the PR interval remains constant with drop beats, and generally it's in the distal conducting system. When I try to describe Wenckebach sequences, I divide it into typical, absolute, and atypical. And I'll show you why now. Let's have a look at the typical footprints of Wenckebach AV sequence. Firstly, there is progressive prolongation of the PR interval, and I call this AV node fatigue. And we can see the PR interval gradually increasing, and then there is a drop beat, a non-conducted P wave. Then the AV node rests and conduction returns, as you can see with the yellow highlight. One of the features, though, that is not talked about very much is that the greatest increase in the PR interval is typically between the first and second beat, with the incremental increase of each conducted beat becoming shorter. So you can see 210, 380, 540 PR intervals, and that the incremental increase falls from the first one to 170 milliseconds to 160. We're not really going to talk about this again, but it is very important because it represents the way we recognize Wenckebach sequences outside the AV conduction. Now, the RR interval progressively shortens with each beat of the sequence, as you can see here. Again, we won't mention this again. The absolute footprint is something that I have always talked about because it's the way when we look on the electrocardiograph, we recognize that this is a Wenckebach AV sequence. Let's define what I mean. Here, the first thing is that the PR interval is longest immediately before the drop beat. There is a non-conducted P wave, and then the PR interval is shortest immediately after the drop beat. So these three features tell us that this is a Wenckebach sequence. However, I'm going to now show you atypical, and when we do that, there are some situations where this won't be so clear as three defining features of a footprint, but nevertheless, you'll be able to recognize it as Wenckebach. The sequence patterns of Wenckebach AV block can be, for instance, 4 to 3. That means that there are 4 P waves for every 3 R waves. And then we have 3 to 2, and then 2 to 1. These are the most common combinations. Clinically, it occurs in younger patients overnight, or less commonly in older patients at any time. Let's have a look at the clinically in a young patient. We can see that during the day, the PR interval is normal. And then at nighttime, you can see now that there is a Wenckebach sequence here. Again, the 3 absolute features. This phenomenon is vagal in the young and is physiologic rather than pathologic in the vast majority of young patients. Whereas, and it is common to the point where it may only have 1 episode in a whole 24 hours of Holter monitoring, and you just may see this feature of longest, shortest, and drop beat. Whereas the older patient, here we can see, can have Wenckebach at any time, but at least there is always first degree block over the 24 hours of the Holter monitor. This may have more significance. Rarely is Wenckebach AV block sequences symptomatic. However, have a look at this case of sinus bradycardia with a classical absolute features of Wenckebach with a pause of 2.5 seconds. And this patient was symptomatic. Electrophysiologically, we can divide it into narrow QRS. It's AV nodal. It's an incidence of 4 to 6% with Holter monitoring, rarely symptomatic. And if you exercise the patient or give them atropine, the Wenckebach disappears. Occasionally, we have to remember it can be intrahisian, and this gets worse with atropine. And this is a much more significant as patients may require a pacemaker. The wide QRS, we all think of this together with Wenckebach, that this has to be distal. But in fact, 75% of the cases still occur in the AV node and then therefore there is a second conduction abnormality in one of the bundle branch blocks. Some of these, of course, are intrahisian and may require pacing. Have a look at this example then. This is a Wenckebach AV sequence, which is obvious and we can see that, but it's associated with a bundle branch block. And this occurred overnight. And one would think that this patient needs a pacemaker. But remember, most of these are still in the AV node, and therefore there is a combination of 2 relatively innocent conduction abnormalities, that is a bundle branch block and a Wenckebach AV block in the AV node. Wenckebach AV block is physiologic, particularly at high atrial rates. Have a look at this example. We can see atrial flutter with 1-to-1 ventricular response. This, of course, can cause sudden death. This is not something that we like to see. And thankfully, in our heart, we have the AV node, which is a blocker. And that blocks the conduction at fast heart rates so as to create something like this with atrial flutter with 2-to-1 block. So these blocks come in maybe, let's say, at 200 beats per minute. Here is a case, though, which is different. Patient is undergoing an exercise test. There is a bundle branch block, and at 100 to 120 beats per minute, there is a pauses noted. Let's map out the sinus P waves, and we can see that with the blue ones now, these are drop beats, and this is a varying Wenckebach block at a low rate of about 110 to 120 beats per minute, which with association of a bundle branch block may be a more serious and would have to consider pacing in these patients, particularly if they are symptomatic, as I think this may well be a distal disease. And now let's look at atypical. Again, atypical have the features of the absolute longest, shortest, and drop beat. But sometimes it doesn't conform to this. But as you'll see in the examples, we actually can recognize this as Wenckebach if we remember the absolute. About 15% of Wenckebach sequences are actually typical. The vast majority are atypical. So let's have a look at some of these examples. Here is one where the greatest increment in the PR interval occurs immediately before the drop beat. So we have 140, 160, 220 millisecond PR intervals, and then it goes up to 580. This is very unusual. And then, of course, follows the drop beat and the shortest PR interval. Again, this occurred overnight and is vaguely, it's due to the vagus nerve, which we'll talk about in a moment. Here's another example where there is a high degree of AV block here. If you look to the right, you can see it's a typical Wenckebach sequence. Now let's look at the yellow highlight, and we can see that there are 2 drop beats, not 1. And there is a significant pause here due to sinus slowing. And what do I mean by sinus slowing? Well, again, look to the left and you'll see it's 5:44 in the morning. And this we call vagal hypotonia. This is a term that I use rather loosely, I admit, and it is often used by people describing younger people who have a very hyperactive vagus nerve and have syncopal episodes. But I think there is a wide spectrum of vagal hypotonia, and I think it's extremely common overnight. Vagal hypotonia is an exaggerated vagal response, often at night. The right vagus nerve innervates the sinus node, and the left vagus nerve, the AV node, via adjacent ganglia. Now, this is something that I use rather loosely, but those in the know recognize that these adjacent ganglia are innervated by the right and the left, but it fits the high vagal hypotonia nicely. So I just say that the right vagus nerve innervates those ganglia around the superior vena cava and the right atrium, and the left is around the AV node. The electrocardiograph shows sinus bradycardia, first degree AV block, second degree AV block, asystole, and ventricular standstill. So there is a significant spectrum here of ECG findings, and similarly of patients who have got no symptoms to very significant symptoms. But most vagal hypotonia occurs at night when patient has no symptoms. Let's have a look at an example. 11:57 at night, typical as we said, absolute findings of Wenckebach AV block, 2.8-second pause, and there is a significant pause within the sinus rhythm with a sinus bradycardia. Here's another one. Looks similar to the one beforehand, but there's no P wave. It's gone. And this is a sinus arrest terminating a Wenckebach sequence. So you can see it doesn't fit that absolute findings we talked about. However, all of us will recognize this as a Wenckebach AV sequence. Here is another one where we can see the longest PR interval, the drop beat, and there is no shortest. This is because there is a junctional escape beat here with the yellow highlight, which comes in before the next sinus beat. You can actually see the P wave. It's at the very beginning of the QRS, and therefore the drop, there is another drop beat which is concealed. So now we have two drop beats. Again, we would recognize this as Wenckebach AV block. Here is one without a pause. Now, this was shown to me and said, well, this can't be Wenckebach because there is no pause, but let's have a look at it closer. Here we can see the sinus P waves, and we can see that there is a very, very long PR interval, almost a second, and then the next one in red highlight is much shorter. So where is the drop beat? Well, it sits in the middle of the QRS, and you can see also in the tracing that there are these beats here, the QRS complexes, which we assume there is conduction. However, I've yellow highlighted it because this also could be a junctional escape beat. We cannot tell the difference. Atrial ectopy and arrhythmias may interrupt or terminate a Wenckebach AV sequences. For instance, here are non-conducted atrial ectopics. Again, very obvious, shortest, the longest, shortest, and there is now an atrial ectopic, which is premature, which is a different shape than the other sinus P waves. And therefore, this is not an early sinus beat, but rather an atrial ectopic. These can be very confusing. Let's have a look at concealed, non-conducted atrial bigeminy. Saying a lot from looking at just an ECG, but there is where the P wave should occur with these atrial sequences, with these atrial Wenckebach, with these Wenckebach sequences. Here are the sinus P waves, and you can see then that there is the one in the shadow, red shadow, are the ones that are not there. Is this asystole? No. What we can see, therefore, is the longest, shortest, and then sitting at the peak of the T wave is a concealed, non-conducted atrial ectopic. And this creates atrial bigeminy. The most confusing, but if you look at it carefully, a very obvious Wenckebach AV sequence. And have a look at the tracing showing that this type of bigeminy lasted a considerable amount of time. This ECG is fascinating because we can see non-conducted atrial ectopics here. Let's map it out and show you. You can see the sinus P waves. We have the shortest and the longest PR interval, and then we have the drop beat. But there is a long compensatory pause, and there is a P wave in the middle of it. And that is a non-conducted atrial ectopic, which follows the sinus P wave, which is not conducted. This happened at 4 o'clock in the morning, and a little earlier, at 3 o'clock in the morning, we can see now the same situation. but let's map it out. And we can see the sinus P waves. We can see that this is a classical Wenckebach sequence. There is the sinus P wave, and now the atrial ectopic occurs before the drop beat rather than after it. And this is in the same patient, 1 hour difference. Here is a low atrial run with a Wenckebach AV block sequence. This is quite obvious to you. The inverted P waves. There is a progressively longer PR interval, a drop beat there, and again, longest and shortest and drop beat. But of interest is that the shortest PR interval is now sinus, and it actually terminates, the drop beat terminates the sequence. We can also see this with atrial tachycardia, and I think you're all aware of this. Here is a short run of an atrial run, and it's approximately 170 beats per minute with the sinus, with the ectopic atrial beats from the focus. And we can see then that there is a green arrows to show this ectopic focus, whereas we can see the blue there demonstrate the drop beats which occur, and therefore they're 3-2 and 2-1 Wenckebach sequences. What about a non-conducted focal atrial tachycardia? Let's have a look above. You can see the classical Wenckebach sequence. Looking below, we can see a run of 3 beats. Fast, and we call this a focal atrial tachycardia. It frequently does not conduct at all, and of interest, this too is a Wenckebach sequence, but not an AV Wenckebach sequence, and we will talk about this at another time. Atrial pacing can occur with Wenckebach AV block, and again, this may be the innocent overnight situation where pacing, where the PR interval or the atrial pace to native QRS conduction gradually increases. And as a result of this, you can see a classical Wenckebach sequence. This does not mean that necessarily that there is a failure of conduction which is of critical concern and needs an upgrade to a dual chamber, but rather this may be one of those physiologic Wenckebach AV blocks. Here is a Wenckebach sequence interrupted by a ventricular ectopic. If you look to the right, you can see the classic Wenckebach. If you look to the left, you'll also see a drop beat. But there we can see now that there is a ventricular ectopic, which is in the middle of a classic absolute sequence. When we look at the ventricular ectopic, we realize that now there is another drop beat. It's concealed within the QRS. So this is a typical Wenckebach AV sequence, but with 2 drop beats because of a ventricular ectopic interrupting it. What happens when you get a couplet? Well, in this case here, it's a classical Wenckebach sequence, but have a look, there is only 1 drop beat. Yes. And then we have a triplet, where now, in this situation, there are 3 drop beats due to the fact that there are 2 within the triplet which cannot conduct because the ventricle is refractory. This is a bizarre tachycardia rhythm. It's actually a Wenckebach. And it's not in the AV node, but rather in the distal conducting system. So let me show you why. Let's have a look at V1. and we'll highlight that. And we can see that there are these sequences occurring for every 3 beats. There is a recurring pattern, with the first showing no bundle branch block, the second showing an incomplete bundle branch block, and the third showing a left bundle branch block. And this is Wenckebach AV sequences in the actual left bundle branch. It has been, and I've seen it in both the right, it's been described, and I've seen it in the right and left bundle branches. And finally, I'd like to show 2 more ECGs, which are bizarre, but represent the extremes of Wenckebach AV block sequences. When we look at this ECG, the first thing that you can see is complete heart block, but it isn't. If you look closely, you'll see that the QRS complexes are different rates. So let's try and see what it all means. Firstly, let's put in the sinus P wave. And if you look at it now, you'll see that the first one is a shortish PR interval, the second one is longer, and this occurs in the second sequence. Then we have the drop beat. So we have typical features of Wenckebach AV block. However, there is also another area of block beats. And if we take one of those sequences, we can see now that there are other block beats, which appear to be for every drop, for every beat. It doesn't conduct. Now, remember, it will allow it conduct because and this is distal to the AV node. So it's a block, a multi-site type block. The first is described was the classical AV Wenckebach, and then there is another more distal to it in let's say the His bundle area. It's a multi-level AV block. It can occur with bundle branch block and syncope and death, and therefore is usually an indication for a cardiac pacing. And to finish off, let's have a look at a reverse Wenckebach AV block, because they exist as well. You can see then that in sequences, there is a long PR interval, shorter and shorter again, but no drop beat. And that's a feature of reverse Wenckebach AV block sequences. It's a sequential shortening of a PR interval, no drop beat. The RR interval is the longest at the beginning, and the RR intervals, that is, they're quite irregular, as you can see. This excludes complete heart block. It's a decreasing block during phase 4 depolarization. And once again, there have been reports of AV block and associated with disease in the His-Purkinje system and bundles, and pacing may be required in some of these cases. So we've now gone through the wonderful world of Wenckebach AV block. You can see that there is such an incredible range of different abnormalities noted. And yet when most people look at this, they fail to see that the different sequences and the significance of them. I'd like to thank you very much for listening.
Thank you, Dr. Harrimond. It's been great. I think it's a very good overview. I myself learned a lot. So I'd like to take this opportunity right now to open the floor. If you have any questions for Dr. Harrimond, you could either type it into the Q&A column, or you could actually type it through the chat box, and I'll be more than happy to read it out. So just keep this time open for any questions. If you do have any questions at all, please submit them now. No questions so far.
Whilst waiting, I will just make comment on there is a very fascinating group of Wenckebach blocks that occur outside the AV node. These, of course, can occur with what we know, the sinus node with sinoatrial block, and diagnosis depends on understanding Wenckebach AV block, as I showed you earlier. It can occur in areas between the atrial muscle and it doesn't conduct necessarily through to the AV node, and it also can occur at ventricular muscle level. And of course, Wenckebach is a feature of other situations, in particular with upper rate limits with cardiac pacing. And maybe if I'm invited, I would like to talk about this at another time.
Certainly, I think that will be interesting. While we'll give it more time for questions to come in, just want to update and give you guys an overview that CardioScan, we do this on a quarterly, at least once every quarterly. So definitely we'll have Dr. Harry come back, to do another session on this. We will also look at different topics. If you do have any topics or requests, just send it in to us, and we will definitely have a look at it. At the same time, today's webinar has been recorded, and we'll make it available through your sales representative in the respective countries. So reach out to them. We'll make this recording available definitely by next week. So if any one of you your colleagues might have missed this session, do let us know. We'll make the recording available to you. Any questions? Any questions on the ground? I don't see any questions coming in. So without further ado, if there's no questions, I want to take this time to really thank Dr. Harry Mon. It was really a good session. Thank you so much, Dr. Harry. Definitely, we'll need your expertise. We'll, definitely have you come back and share with us more in the next few sessions. Thank you, Dr. Harry. Thank you all for joining us today. We hope that this snapshot, this 40-minute session is good in between your work lunch time, and we'll hope that you've enjoyed and understand a bit more about Wenckebach, and definitely with Dr. Harry Mon in helping us talk about this topic. We'll hope to do more in the coming session.